or increase in the BMD. Now the second thing comes when BMD is high and we are giving certain drugs which doesn't affect SGLT inhibitors. They are also better molecules. And third drug which should not be given, which should be avoided, is pioglitazone. So this causes loss of
depends on modes of therapies. First is the non-pharmacological treatment, which includes the exercise, improving the nutrition, and second thing is preventing the bony injuries. The second part of the therapy comes with in the pharmacological category, where we can prescribe calcium, vitamin D supplements, bisphosphonates, and various other selective estrogen receptor modulators. There are a lot of drugs available as per the requirement of the patient, age of the patient, weight of the patient, and his physical activities. Thank you.
What do you say about
Early part of bisphosphonate? It is one of the safest drugs available for use. It is used orally, 70 milligram per week. It's used, but the only thing associated with alendronate is it has a tendency to cause esophagitis in 1 to 2% of patients. So it should be given safely with a lot of water, and after taking alendronate, patient should be sitting upright for half an hour.
in fact the osteoblast activity?
it also reduces the requirement of the insulin. So this can be chosen, and only few precaution has to be taken. That will be taken, then this will be very good polyphosphates, and this will help in the mineralization of the bones.
And
metabolic syndrome, number one thing which is very caution. As far as treatment is concerned, any treatment what we are giving in type 2 diabetic mellitus will leads to weight gain. So the latest molecule like SGLT2 inhibitors and pioglitazones. These pioglitazones, the patient who are taking pioglitazone for a long time, they are more prone for neck fracture, neck femur, and even patient of SGLT2 inhibitors also, the osteoporotic changes, they are very common. So one has to be very cautious when we are giving these two molecules in diabetic patients.
fine, Dr. Chopra. Let us come to the next question. What are the challenges in treatment? This has to be replied by Dr. Chopra.
More than 30. Means obese, we can divide the patient like obesity grade 1, grade 2 and grade 3. Depending on the severity of the obesity, we are having the cardiovascular risk in obese patients. Obesity as such is one of the constituent of metabolic syndrome. In case of metabolic syndrome, the insulin sensitivity that is hampered down. So there is a more insulin level inside the body, and insulin sensitivity is also hampered down. And these patients of metabolic syndrome, they are not only obese, they are more prone for hypertension and atherosclerotic cardiovascular diseases. All
Which are comprising of metabolic syndrome, hypertension, obesity, if the hypertension is concerned, and this will prevent the certain complications of diabetes also. Now the third thing is that in the obese person,
first drug of choice is ACE inhibitors. If the patient is not able to tolerate ACE inhibitors, then only ARBs. But make it a point, in previous years, sometimes the ACE inhibitors and ARB combination they were used. Combination of ACE inhibitors and ARB should not be done.
We have to be very careful to see whether the fetal growth is being restricted or not, whether it is going to be delivered by premature birth or not. These two are the very greatest challenge for the fetus. And for the mother, usually hemodynamic changes are done. So we have to again be very careful. Because the hemodynamic changes are so fast in pregnant mothers. I think so even the best echo is very difficult to predict what sort of liver pains they will go. So we have to stick to that. Thank you.
Yes, we have to see that is the mind.
Otherwise, chronic hypertensive patient can also be pregnant, or any hypertensive
Yeah,
patient.
this is the next question. This is the second part of that. that different eclampsia, HELLP syndrome, these are the classification, and we treat at different type of using drugs, and the delivery of these patients, it is the standard care. It is the definitive treatment for the treatment of hypertension during pregnancy. Actually, this hypertension, why it occurs? The etiology of this hypertension is not clear. And hypertension, as we think that it is because some pathophysiology is there. But this drug, it acts on both alpha and beta receptor, so it controls the blood pressure very well. And second drug is magnesium sulfate, and that is good vasodilator, and it controls the convulsions also. So in this way, we can manage these hypertensive disorders in pregnant bleeding. And this is one more the classification of HELLP syndrome, and this is very severe form of PIS, that is pregnancy-induced hypertension, and that should be there.
And Rubica just followed. HELLP syndrome.
HELLP syndrome. I'll add one more thing, that when we are most of the patient, later on they develop various complications of hypertension. And
Only when the patient is in a
now I'll tell you,
In severe PIH, we are also giving severe PIH.
if the patient is not responding with labetalol.
With labetalol.
we have to give IV labetalol, 40 milligram, we have to repeat it after half an hour, and we can give up to 200 milligram labetalol, which is a protocol. And if you follow this protocol, most of the patient will be benefited.
Excuse me, sir. 1 minute. Like Dr. Amita, cardiovascular or renal, and if the patient is not followed, 100% they go for chronic failure, which is unable to conceive. I think the most of them must be doing अगर डेंगरे का case, because I was handling first two delivery, she had very good, normal. Third delivery, she started a bit early hypertension. So that was the phase in which hypertension is started. That is also very important.
Madam, I suggest at this gesture, at this point, that we have to tell every expected mother or a lady who got married that she should check her blood pressure before conceiving, because there are fair chances that she might be having mild hypertension with very precipitating, and she might be having certain organ damage. So we have to check blood pressure just after delivery, or we have to tell them that they should be cautious before conceiving.
Thanks.
Definitely, as sir said, they will develop all these cardiovascular disorders in future. So we have to take adequate postpartum care. Postpartum care should be adequate.
One more addition, if the patient is not responding with labetalol alone, then we can add calcium channel. We can add, but no diuretic and no sedative, no insulin.
It's really a
Post
very,
delivery we can give. Post delivery we can give.
very tricky situation.
Before conception. But there are so many patients when BP was absolutely normal at the time of conception. It increases either in the first trimester of the pregnancy or in second trimester of pregnancy. This is not necessarily BP because normal before conception could be normal only throughout the pregnancy.
This may be the true chances that those patients who develop hypertension in the first trimester can be excluded. So my saying is this only, that there are few persons who can develop in the second or third trimester, but those ladies who are having incipient hypertension, they can be detected. And most important, the end organ damage we have no judge. So we have to follow this way.
Excuse me, sir. So for it affects the brain and most common is mitral stenosis. So this is a very important because preconception counseling is very important. And if the after this is diagnosed, as I told you, it is diagnosed by in ladies by a gynecologist. How much her heart is sacrificed, how much you can tolerate, and regular physician care is always there. And Yuko has done a lot to
But if the mitral valve orifice is less than 1.5 centimeter square, then the chances of development of ventricular cardiac failure is more. Because in case of pregnancy, as such the volume, that volume is more. In case that is the physiological phenomenon. And because of the more blood volume, the heart rate is also more, the stroke volume is also more, the cardiac output is also more, the chances of airway pressure is more, chances of development of cardiac failure is more when the mitral valve orifice is less than 1.5. So before going for pregnancy, the rheumatic patient should be subjected for echocardiography to have the exact size of the mitral valve orifice, and if the patient is having huge cardiomegaly and MV mitral valve orifice is less than 1, the pregnancy should not be advised. It is contraindicated.
Reserve of the heart.
And it's very difficult. Any patient of PMV can be done.
Surgery is being done in antenatal period at very good centers. So I have a couple of patients, those have gone. Only thing is that they have to be kept on.
If the mitral valve is not calcified, it is only stenosis, and it is the same of 1.4, 1.5, the patient is symptomatic, then usually the heart center can do PMV, that is balloon mitral valvulotomy.
What is the difference in hypertension or diabetic compared to non-diabetic patients? What special care would you take to treat such patients? This question is for Dr.
So, as all of us know that hypertension can lead to atherosclerotic cardiovascular disease. In diabetic, which is more, while in cases of simple, not diabetic, percent is less. So the treatment option is always, if the person is having blood pressure below 140 and 90, he can be managed with a single drug. If the blood, lifestyle modifications in it. If his blood pressure is up 6100, we have always choose the double or triple drugs. And then make sure. Apart from this, we have to take care of a renal function test. If the GFR is less, then we have to take due care of them.
Carefully treating, and one should be very cautious because AC inhibitors we cannot give. ARBs, AC inhibitors and ARB only is the safest choice, and other drugs, suppose beta blockers we are using in case of diabetes, then the chances of peripheral vascular disease is more. So one has to be cautious when we are giving beta blockers in case of diabetic heart disease. We can give beta blockers, selective beta blockers, as the patient is having associated disease.
What is your opinion?
Because it was noticed in certain journal that status cannot prevent but it is a very good drug. It will always have a good effect on the primary prevention as well as the secondary prevention.
That is for the period of it.
Right.
And for the period of it. Irrespective of the limit profile, every diabetic patient should be on statin therapy. When hypertension
Complications observed during pregnancy, are they due to physiological changes or else? Dr. Neena, can you do that?
Yes, pregnancy causes significant and inability to adapt these physiological changes might lead to the development of cardiovascular disorders. And these disorders, if present during pregnancy, may leave permanent damage in the metabolic or vascular damage, then there may be occur. And these all changes, they have clear association with the future development of cardiovascular diseases, like they may go into stroke, cardiac failure, ischemic heart disease, diabetes mellitus, they can develop later on. Renal
the changes is what normally occurs in all pregnant women. Any lady will have more blood volume, we have already said. The volume is more, heart rate is more, stroke volume is more, cardiac output is more, so transmitral gradient is more.
Understand? Because number one, the tubercular patient, in the diabetic patient, the number of cases of tuberculosis were more than non-tubercular. Number two, during treatment, first we have to control diabetes, then start treating. Until unless we control diabetes, ATT will not work properly. Number three, the relapse rate and FDR cases are much more in diabetic cases compared to non-diabetic cases. So, relationship between diabetes and asthma tuberculosis is much more valuable than bronchial.
Up to 37% of the diabetic patients.
That is not only asthma. In case of diabetes and obese, diabetic patient usually when type 2 diabetes they are obese, and these obese diabetic patients they are having sleep apnea, and because of the sleep apnea they have the respiratory distress, they have hypoxia. Second point is when we are treating asthma, especially in case of asthma, most of the time we are giving corticosteroid. So one has to be very cautious when we are using corticosteroid therapy in case of diabetic patient, because the steroid therapy leads to rise of rising of the blood sugar.
In both the conditions, there is always oxidative stress, there is an ongoing inflammation and hyperglycemia. So this all leads to development of COPD. So development of COPD is more in the diabetic and both are interconnected. We have to take care of it.
First, through the question, should calcium and vitamin D3 also prescribed with other treatment options? Which should be preferred, vitamin D3 daily, weekly, or
Age of the patient, sex of the patient, and undergoing diseases which he has along with the osteoporosis, he or she has along with the osteoporosis. Calcium and vitamin D is commonly prescribed. Vitamin D is normally taken in a 70 kg man or woman around 400 to 800 international units, and calcium is taken between 1000 to 1200 milligrams. There are a lot of other supplements also along with calcium and vitamin D, like magnesium. Magnesium helps in the absorption of calcium into the bones. Similar advantage with vitamin K. And I think the osteoporosis prevention in a diabetic patient is more related to his awareness of his problem. Lifestyle changes.
Combination should not be used for a long time. Any patient taking PPI for a long time will lead to decreased absorption of calcium, will lead to decreased absorption of magnesium. So there are very fair chances of osteoporotic changes in the bones with the
Cracks, we don't take much consideration.
Dr. Gideon, how commonly do you come across osteoporosis?
Incidence is more. In pregnancy, we can't joint pain, hip pain. So we should consider osteoporotic changes in those cases. And that osteopenia that causes severe back pain and hip pain. So we should consider for osteoporosis during pregnancy and after pregnancy. And for osteoporosis, in such cases, we are giving vitamin D3 and calcium, as Rahul already said what we should give. And after menopause, almost 80-90% female they are suffering from osteoporosis, and for so many drugs, all orthopedicians and gynecologists they are prescribing.
Supplement vitamin D or not. So that has become a routine investigation nowadays. And they put up girdle pain, not a pain, pelvic curve. So estimation of vitamin D is a very important tool, and that has become mandatory now.
Yesterday,
Which we are not taking. No one can.
yesterday I have seen one of the lowest scores of vitamin D in my life, 3.7.
Decrease, and secondly, the enlarged uterus presses the stomach. That is why the stomach is pressed.
Articular corticosteroids. I think the dose of hypoglycemic drugs can be increased in some cases depending on his
Good interaction. And now I request Amit to please take over. Thank you so much.
Any suggestions from the house? That is most welcome.
They are busy.
Any suggestions, any queries from the house?
They are busy.
I think a little late, but